Hi all, welcome, good evening, salam, and good to see all of you tonight. Hi Anand, how are
Very
you?
well. Hi Abhishek, how are you?
Perfectly
I'm
fine.
good. I'm good. Thanks a lot.
And today is the second day of our masterclass session with great Dr. Ajay Bajaj sir. And we know anesthesia is the most complicated thing for private practitioners, and we all face, irrespective of any experience we have. For a beginner also it is a problem, and even most experienced, like say people with more than 20 years of experience, do face problem one day or the other day. So I think Dr. Ajay Bajaj will be clearing all of your doubts today, and I we welcome Dr. Ajay Bajaj sir to the show. Welcome sir.
Thank you.
Just to add to what
How are
Abhishek
you?
was saying, Abhishek, I have been his patient and I know that I am a very bad patient. So I can give you first-hand experience that he is awesome in everything else, but surely in anesthesia, for sure.
Kya baat hai. That's a big honor for me, Anand.
Thanks a lot, sir. You are amazing.
Thank you. Thank you.
I don't even have a formal introduction of sir, but I am pretty sure anyone and everyone who does endodontics in India would have heard sir speak at some point in their life. It is like every Saturday, Sunday, we plan to go for a movie, sir goes to take a lecture. So every day when you follow him on Facebook, every Saturday, Sunday, we plan to go for a movie and sir is going somewhere to take a lecture. So I guess let's not waste more time. Sir, the stage is all yours.
Okay sir.
Thank you. Thank you, Anand. Thank you. And
Bye, sir.
thank you. Bye. And as you rightly said, Abhishek, one of the most important topic, anesthesia. Anesthesia in endodontics. And we all have. I just want to ask my viewers, when was the last time you attended a lecture on anesthesia in endodontics? You may be 5 years, 10 years, 15 years, 20, 30, 40 years in your practice. But when was the last time you attended a lecture on anesthesia and endodontics? I remember I was lecturing the same topic a couple of years ago in Andheri only, in my area only, and one of my very senior practitioner in my area, Dr. Kapadia, he said he has never attended. He's like practicing for more than 40 years now, and he said he never attended a lecture on anesthesia and endodontics. And we all face problems, we all face challenges. Unfortunately, this topic is more least spoken about. I don't know why, but it is. This is what it is. So let's talk about anesthesia. I'm going to make it simple. I really, you all know me. If you have heard me, I really do not like to talk much about theory. So talking about studies and other things is not my forte, not my cup of tea. But I'm going to give you maximum possible practical tips. Okay. So failure in achieving complete or profound anesthesia is, of course, an issue we all face. And well begun is half done. That is what Aristotle said one day. And we all know it is extremely important to have that smooth phase in the clinic. Typically in patients' work, this doctor's hand is heavy, this doctor's hand is light. What is that heavy hand or light hand? It's basically because how we give anesthesia. Now, pulp is a mysterious tissue, right? Whenever it gets inflamed, acute pulpitis almost always leads to death of the pulp. But it cannot, many times it does not die that easily. As the great Professor Grossman said, some pulp will die even if you closely look at them, right? A small exposure and that pulp is surely going to die. And while others can't be killed even with an axe. So we really work hard, but that just doesn't get numb, that doesn't die. Okay, so it's even if you use an axe, probably will not die, and that really troubles. I have a very big referral practice. A lot of dentists in my area refer their patients to us. And I say that about 20% of the patient, every fifth case which is referred to me is for the same reason. Doctor calls me and tells me, Ajay, I have a patient here, he's very sensitive. I tried giving him anesthesia and anesthesia did not work well. I tried it next time again. Every time I try to work on this tooth, patient jumps in chair. I don't know why. His lip is numb, his tongue is numb, but somehow that tooth is just not getting numb. He is in pain. And the patient comes to me. We almost do the same procedure, but the tooth goes numb and we complete that root canal in single sitting. When the patient is getting pain, that simply means the pulp is still alive and kicking, and that's a good reason for me to complete root canal in single sitting. And we finish in one sitting. Patient is extremely impressed. Doctor, what did you do? What that doctor did not do, and what did you do? Did you use some other medicine? Did you use some higher dose of medicine or something like this? In patient's word, they ask me. But we know there are some techniques, there are some tips and tricks which we all use, and we can make the things simpler. Okay, so here is a case which came to me this was around a year ago. Okay, this was around same time, 9 o'clock in the night, and this patient suddenly appeared in the clinic. This is the time we closed the clinic in Mumbai. Those who are viewing us internationally, we have in India we usually practice in 2 sessions. No more actually, not in COVID days, but otherwise we have morning session, we have a break in the afternoon, and we work till about 9 o'clock in the night. So this patient came at 8:45, and he had acute pain. This was lower right 7, and he had pain. And he said, "Doctor, I have pain in this." And this is old patient of mine, Parsi guy, staying in Australia. And he said, "I'm going to Australia tomorrow." I was like, "Okay." And I'm in great pain. Please do something about it. I was like, yeah, this is not the time. This is 9 o'clock. How will I, meaning if I have to start with your root canal now, I can see there's deep cavity. And if I have to start with your root canal now, this is not a great time to do it. Okay. But if he's in pain, it is my duty to do. So I was working on other patient. I told my clinic associate that just give him anesthesia. By the time I finish my patient in next 15 minutes, he will be anesthetized, and then I can start. She was also leaving for home. I let her go. She injected him. She gave him the block, mandibular block, and then she left. And then I tried to start with this case. And patient had a lot of pain. The tooth was just not numb. I asked him, "Is your lip numb?" It was not. "Is your tongue numb?" Yes, he could be some numbness on the tongue, but the lip was not numb. I wondered. She gave anesthesia, but in spite of that, and it's been 15 minutes and he's not numb. I injected him again. And after injecting him again, waited for 15 minutes. So it was like almost 9:30. I was getting calls from home. My chairside assistant also needs to go home, right? But patient is not getting numb. How do we work? So this was kind of a little panicky situation that what do we do? Okay, so I remember I have he's been my old patient. So he had come to me like few years ago, and I have his old OPG. Let me see the OPG. And this was his old OPG from 2015, as you can see. And this was the tooth which was for RC now. And I saw something on this. We changed the technique and it worked. And patient was completely numb after that. Like the tooth went completely numb after 10-15 minutes. And we could do root canal in single sitting. Of course, it was pretty late for us in the night, but at least patient was relieved and he could fly next day morning to Australia. So what was the trick? What was that? We'll come back to that in some time. Okay. So good profound anesthesia is one of the most important steps in root canal therapy. Okay. Well begun is half done, right? And if that anesthesia does not work well, even if you do instrumentation well, you do observation well, you do everything well, patient will, when we'll get up out of the chair, he will say, "Doctor, it was very painful." Okay. If at all, patients, we used to tell patients about root canal treatment. We used to explain them, okay, if you want to save the tooth, there is something called root canal treatment. Don't extract, we will do root canal and save. I think most of us don't really need to explain patient what is root canal treatment now. They already know about. When I started my practice, that time we used to explain, but no more, right? So we don't really tell them much about root canal treatment. In fact, they come back telling us, "Oh, root canal, it is very painful. I don't want to do it. And patient panics listening to the word root canal." Okay. So that pain sensation which patient goes through, we have to work on that, and we have to see to it who created that panic. A few years ago, a few decades ago, patient did not know about root canal treatment. Now they know, but they strongly associate it with pain, and we need to eliminate that. So one of the way is starting with anesthesia. Anesthesia has to work with. We wonder many times, that if I have to do extraction of the same tooth, it will be painless. But if I have to do root canal for the same tooth, it will be painful. Isn't that right? So we all go through these issues, and let's see how do we do it. So one of the things which we do is nothing will happen to you. Now, this is the biggest problem. We give anesthesia and we want to assure the patient, okay, it will be fine. And we tell him, nothing will happen to you now. Don't worry, I've given you anesthesia. That's a wrong statement. We all know that. Something will happen, especially in mandibular teeth. We know in maxillary teeth, many of the times, there are no issues. We can work smoothly. About 90% of the cases, we will not face any challenges. But in mandibular teeth, in about different studies are there, and from 50 to 90% of the cases, there are problems, especially in molars. So what happens exactly? Where do things go wrong? Okay, so failure in capturing complete or profound anesthesia, it's one of the biggest worry of most of the dentists. Usually problem is more in mandibular teeth. Here it reminds me of one small incident in my life. Okay, my father is also a medical practitioner. So this was way back. I completed my MDS in 2002, and he had pain in his lower right first molar way back in 2004, so around 16 years ago. Okay, so it was acute pulpitis. He couldn't sleep properly one night. Next day morning, we decided to do root canal for him. I took him in the chair, gave him the block, and started working on the tooth after 10-15 minutes. And a typical scenario, we call it VIP syndrome. More important patient is, and more are the problems. If it is patient is close to you, patient is important in your life, the problems can always be more. So if I have to work on my parents, anesthesia will probably work. If I have to work on my wife's parents, it just wouldn't work. It will just refuse to work. I hope my wife is not listening to this, but this is typically, it worked on your parent and it is not working on my parent. What did you do? What happened exactly? Okay, so they are VIPs, and in spite of that, it doesn't work. So we have this VIP syndrome, and many of the times we have these problems. So I was just joking. So what happened in my dad's case, anesthesia did not work well. We still went ahead. I told him, okay, this happens. There's always some little pain, and we have to live with it. Just manage for some time. And somehow you extubate the pulp, and the pain goes away. And I completed my root canal in single sitting. Moment I completed the root canal, he got up from the chair and he patted on my shoulder, saying, "Oh, my son, you need to still learn more. Beta, abhi teko aur seekhne ki zarurat hai." Okay, that is what he told me. And that was like, okay, Dad, why are you saying something like this? He said, how can there be pain? There cannot be any pain. I was like, no, it happens. And I tried to explain the science in dentistry. And he refused to accept. He said, I'm also a medical practitioner. If something happens, if I'm working, if I tell you I'm going to do a surgery and there can still be pain, will you accept it? No. So there should not be any pain. There must be something. There must be some tricks. There must be some equipment. There must be some science behind it, which will help you in minimizing this pain. I was like, okay, that really started a big thought process in my mind. And then when I started working on this problem, okay, and we all face this challenge, and let's see how it goes. Okay, so we all know that the clinical studies in endodontics with patients with irreversible pulpitis find that inferior alveolar nerve block alone between 19 to 56% of the time it fails. Okay, or it is found successful only this percent, meaning around 50 to 80% of the patients it fails, right? It is difficult to achieve. And we all go through the similar percentage, meaning if I have done, say, 10 lower molars in last 1 week or 10 days, I know that in 4 or 5 or 6 or 7 of them, especially the vital teeth, there is going to be some pain to the patient, and I need to do something about it. Okay, so first thing first, simple thing. How do we give our anesthesia? What do we do? How do we do? So there are some innovations which are shown over here. Now, viewers, let's imagine that we are giving anesthesia for root canal for upper teeth. So what is the anesthesia we give? For upper central lateral canine. Okay, some of you will give blocks, some of you will give infiltration. Well, infiltration works well. I will give infiltration, a labial infiltration and palatal infiltration. Okay. Then 4-5 premolars. What is the anesthesia I will give? Maybe buccal infiltration and palatal infiltration. Okay. And for the posteriors, okay, 6, 7, 8, I will give again a buccal infiltration or a block, whatever. Again, buccal infiltration works well. And palatal, are you sure? Okay. Then we go for lower teeth. What is the anesthesia we give for lower? Okay. We literally hold the mandible in 3 fingers. Isn't that right? The index finger goes on the anterior border of the fossa. Anterior border of the mandible into the fossa. The index finger goes on the posterior border of the mandible, and the middle finger goes on the lower border of the mandible. We literally hold the mandible in 3 fingers, and from opposite side, I will go. We say it premolar approach. Okay, we go and we are supposed to hit the bone. Okay, we go and hit the bone, and then we probably will do some aspiration and we will start injecting over there. Okay, then we'll try and take the needle on the same side for which nerve? Lingual nerve, and then we'll come out. And if it is a molar or something, we will definitely give a long a buccal shot for long buccal nerve. Is that right? Okay, couple of things over here. First thing, tell me the truth. How many times you just go half or more than half of your needle is gone inside and you hit the bone? Sometimes it hits very early, or sometimes you just don't hit the bone. The needle keeps going in the whole 1.5 inch needle goes inside, and then we panic because I know that if I inject too deep, I may be injecting in parotid sheath and patient may lead to facial palsy. And I don't want him to experience something like this, right? So we do not want to have him that kind of experience. So what do we do over there? Okay, why does this happen? Both rami of the mandible, left ramus and right ramus, both rami of the mandible, we imagine that they are parallel to each other. So this is, I have a piece of mandible over here. So if I see this, you can see it over here. Okay, if I see this over here in the jaw, we feel that it is this mandible, the ramus, they are parallel to each other. They are like this. They are vertical and they are like this. Okay, that's why I expect the needle to hit. Okay, but it is not the truth. They are slightly at an angle, convergent anteriorly. Okay, so there is an angle which we see, because of which when we go with the premolar approach, we either hit the bone, or if this angle is tipped, I will completely keep going parallel to it. Okay, and that is why sometimes I just miss and I keep going deep, and naturally the anesthesia is also not going to work well. Okay, or if this is almost parallel, sometimes I just go and I've hardly entered a few millimeters inside and I hit the bone. Okay, so what do we do? If I hit the bone early, I will take my needle towards canine. Okay, I will take it towards canine so that I can go a little deeper. If I just don't hit the bone, I will take my needle towards molar, first molar, and then I will inject. Okay, so I can play with this angulation, and I can play this angulation and say to it that I hit the bone at a proper place. So this is a small trick which we can play, and we can hit the bone. Now coming back to innervation. Okay, so if we know what do we have in innervation for anterior 1, 2, 3 in upper jaw, what we have anterior superior alveolar nerve in giving innervation to upper 1, 2, 3, 4, 5 and mesial root of 6. What we have is middle superior alveolar nerve and remaining posterior superior alveolar nerve. If you see all these teeth, none of the root, none of the root or the pulp is getting any nerve supply from nasopalatine nerve or greater palatine nerve. When this nerve supply just does not exist, there is practically no need to give anesthesia on the palatal side. There's practically no need to give. Okay, in very, very rare occasion, I will give palatal anesthesia. So when I'm doing upper teeth root canal treatment, I will not give palatal anesthesia. Labial buccal anesthesia is more than enough. Most of the times, even infiltration is more than enough. If I require, I will use interligamentory anesthesia as an adjunct, but I will try and avoid giving palatal anesthesia. What happens if I give palatal anesthesia, and why do I avoid? Because the most painful anesthesia in the mouth is palatal anesthesia. Okay, so injecting on the palate is painful. I eliminate that. I always say the best patient in my practice is a patient who has got at least one root canal done with someone in the past. Okay, and he will typically say, "Oh, doctor, this was smooth. This was simple. The pain was less. Are you not going to give me injection on the from inner side also?" So we can avoid. Meaning he sees the simplicity in the treatment. Just buccal shot, and that should be more than enough. Now, what happens when I inject on the palatal? On buccal side, I typically will inject almost the full carpule of my this thing, needle, right? That is around 1.8, 1.7 ml. But on palatal side, I'm going to inject say 0.2 ml. Is 0.2 ml enough for that area to make it numb, penetrate through a very thick cortical bone and reach to palatal root and make it numb? Do you really think so? If 0.2 cc was enough for palatal root, such a big one, then probably on the buccal side, did we require so much of it? Maybe 0.4, 0.5 cc was enough? No, we required more. The bone on the buccal side is quite porous, whereas on the palatal side, the cortical bone takes 5 times more time for anesthetic solution to reach to the palatal root. So the buccal anesthesia is more than enough for, in most of the cases, for even palatal root. Okay, so we do not require palatal anesthesia in most of the cases in maxillary teeth. Okay, coming back to mandibular teeth, what is the nerve supply of mandibular teeth? So in mandibular teeth, what we have is inferior alveolar nerve, okay, which will give branches to all the teeth. Okay, now does any tooth get nerve supply from lingual nerve? What does lingual nerve do? Lingual nerve supplies to anterior two-thirds of the tongue, okay, and lingual mucosa. So do we really need to take, when we go say premolar or canine to molar approach, we enter inside and we take the needle on the same side for lingual nerve. Do we really need to do that? Do we have to do anything with the tongue? No, not really. So we need not do that, okay? And then again we give a long buccal shot. What does long buccal do? Where is long buccal used? Long buccal does not really have any role as such in molar anesthesia, because long buccal basically is for buccal mucosa. We do not really need to worry about that. So there is no need to give long buccal. So when I am injecting for mandibular teeth, I am simply supposed to going inside, okay, inject and just come out. Now you will say, we were taking it on the lingual side and then taking it out. So we were anesthetizing lingual nerve, then we were giving buccal shot also. And in spite of that, I was not getting enough anesthesia. And you are asking me to cut down on anesthesia in lower and upper. And how are we going to have profound anesthesia? So let's see those steps. Okay. So there are some common points associated with inferior nerve block, and we should know these points. Okay. And first thing, very important thing, we all should know. We ask our patient, is your lip numb? Is your tongue numb? Okay, and we see that, okay, that is a sign that I should start working, but that's not the truth. So lip numbness indicates pulpal anesthesia. No, that is not true. Okay, that's not really the thing. Your lip can go numb, but your pulp may not go numb. Okay, that does not guarantee pulpal anesthesia. And we all see this. We all see this. Lip can go numb really fast, but pulp will take really, really long to get anesthetized. Okay, soft tissue sticks indicate pulpal anesthesia. Unfortunately, like lip numbness, or if you check the mucosal sticks or with the sharp explorer, you check on the mucosa and other thing, you check it on the tongue and you see, okay, that has gone numb, then the pulp has also gone numb. No, that's not true. Okay, although the nerve is common, but the innervation is different. Okay, so that's not true that it is numb. Okay, so most local anesthetic solutions diffuse through the plasma membrane of the channel. Okay, and in general, pulpal pain perception takes longer time because there are two types of fibers which we have: C fibers or thin myelinated delta fibers. Okay, so when we are working on these fibers, they take really long, especially the C fibers take really long. So it may not go numb completely. Okay, so lack of accurate inferior nerve block injection causes anesthesia failure. This is what we always think about. No, not really. Okay, so they did some ultrasound and studies, or with the radiographs with the needle inside. They did some studies, and they found that's not always the case. Of course, we need to give anesthesia properly. We do not lose some anatomical landmarks, but that is not always the case. Okay, we call it a blind block, but it is not really a blind block. How it is not, I'm going to come to that in some time. Okay, so once the lip numbness is obtained, pulpal anesthesia is not far behind. As I said some time ago, no, that's not the truth. Okay, so lip is numb, not always that a pulpal anesthesia is achieved. Okay, so of course it goes this way: lip goes numb first, and then the pulp. Okay, but for pulpal anesthesia, we must wait for at least 15 minutes. Okay, and then it should be numb. So don't, if given anesthesia, lip has gone numb in 5 minutes, you start working on that molar, no, you are going to face problems. Pulpal anesthesia takes time, and we need to wait for minimum 15 minutes, and even that does not guarantee complete anesthesia always. Okay, failure in molars and incisal teeth is the same. No, that's not the truth, because studies tell us that pulpal anesthesia failure occurs around in 17% of the molars, in around 11% of the first premolars, meaning molar and premolar is almost similar, and around 32% of lateral incisors. Okay, again 100% of the patient had profound lip numbness. That is how this checked in the study. The lip numbness was there, but pulpal anesthesia was not there everywhere. Okay, so what is this? Lip numbness is there, but pulpal anesthesia, there is difference in all these stages. Now the thing is, we have a nerve bundle, and then there are some fibers which are there. The deeper fibers give innervation to molars, the incisors, and the superficial fibers from the deep bundle give innervation to the molars. Okay, so molar anesthesia is better, but because it is the deeper fibers are supplying to the incisors, that takes longer time to anesthetize. Why they took lateral incisor in this case? Because central incisors sometimes have cross innervation, so we may get some wrong results. That's why lateral incisors. Okay. Now there are different kind of anesthetic solutions. We use lidocaine, we use articaine. Okay, and there is some, I don't know why this fear is there in people's mind, and articaine causes paresthesia and it should not be used for nerve blocks. I don't know why people feel this. I use articaine and I use it for 100% cases. I don't know whether we have lidocaine in the clinic really. Okay, so this is questionable. So this is a famous study which was done in this study. Progrel evaluated patients referred, and he found that he gave inferior alveolar nerve block, and he found that 35% of the patient had damage because of, meaning about the cases where there were damages, 35% of the cases were because of lignocaine formulation, and 30% cases were because of the articaine formulation. And in all, there were 14 cases from 11 million injections. That is 1.1 crore injections. Okay, that's a very small number. We don't know whether it could be because of anesthetic solution. It could be something even more than that. We don't really know. And if at all, if I have to go by study, the percentage was more with almost a similar percentage, but it was more with inferior alveolar nerve. Okay, incorrect needle bevel orientation causes failure. Is that true? Again, not really. Okay, although we should know about needle bevel, how we should be directing it away or towards the mandibular ramus, but inferior alveolar nerve blocks does not really affect because of that. Okay, cross innervations is the main reason for failure. It is actually an important thing for me, and cross innervations, I feel, play a big role in inadequate anesthesia, especially in mandibular teeth. Okay, so mandibular teeth have a different set of innervation. The main nerve remains inferior nerve. But apart from that, we still have lingual nerve, we have buccal nerve in that area, we have cervical nerve endings which are coming in that area, we have cutaneous coli, then we have superior and inferior laryngeal branches of vagus nerve coming in this area, okay, and they are known to occasionally innervate the teeth, okay. So there is a very complex plexus which we have, okay. So what exactly happens and what is this percentage? What should we be taking care about? Okay, so here goes the picture, and in this picture, if you can see, this is how the mandibular nerve starts, and it gives the main branch, which is this, which is called inferior alveolar nerve, which enters to the mandibular foramen, and it is going to give branches to all the teeth. Okay, just before entering, around 1.5 to 1.7 centimeter before that, it branches into myloid. It gives a branch to myloid nerve. And this is the myloid nerve, which is extending further and which supplies to myloid nerve. And myloid nerve is the it supplies to myloid muscle, and myloid muscle is the muscle which forms the floor of the mouth. So this is my mandible, and then there is a floor of the mouth, and that has been supplied by myloid nerve. Now, in about 35% of the cases, that's a big number. In about 35% of the cases, in case of molars, myloid nerve gives a minor branch to the molar, and 35% is a big number. That means if I have 3 roots, out of 3 roots, 1 root is supplied by myloid nerve, and that's a big number. That's how typically molars give us trouble. Okay, so as we learned some time ago, that I just need to go from opposite side, canine to premolar, canine to molar approach, enter inside, inject, and come out. Okay, I don't need to take the needle on the same side for the lingual nerve because I have got nothing to do with lingual nerve. Okay, but I can use we usually give a buccal shot for the long buccal nerve, but long buccal nerve doesn't really anesthetize any of the pulp. Okay, so instead of giving a long buccal shot, I will prefer to give a lingual shot for myloid nerve, okay, which is very important. 35% of cases, that's a big number. Okay, so I should be able to take care of myloid nerve very well. Okay, so there's another innovation which we get is cervical nerves which supply. So plexus of cervical nerve, the cervical nerves come from behind and they follow lower border of mandible. They reach to mental foramen, and in mental foramen they enter inside and go up to molars. So that's really strange because all other innovations are coming anterior. This is the only innovation which is going posterior, distal, and going up to sometimes even wisdom tooth. Okay, so if at all, if I have to give a buccal shot, I should be giving actually close to mental foramen. That is in area of lower premolar, apices of lower premolar. That's the area I should be innovating. Okay, so cross innovations cause majority of the failures in incisor teeth. Is that the truth? No, we just saw it is not the case. It is basically the deeper fibers which supply to pulpal tissue is usually the result. Okay, so why don't patients achieve complete pulpal anesthesia with inferior alveolar nerve block? Okay, so the central core theory probably is the best explanation. That is what in today's that we all know about. Okay, so what is that? So it states that the outer nerve supply, outside the bundle supplies to molar teeth, and nerves inside or from the inside bundle supply to anterior. So this is the bundle which we have. This is the core bundle and this is the mantle bundle. Okay, so outside fibers will supply to molar teeth and inside fibers will supply to anterior teeth. Okay, I'm talking about the pulpal tissue. So there is always a theory of lower pH inflamed tissue which also plays a role, but I don't know, meaning this is like too theoretical. We really don't know what is actually exactly happening. So whenever the pH is lower, inflammation is lower, so the brain does not get proper signals, and because of that there can be issues. Okay, so what do I use? I do not use bottles. I use and my preferred anesthetic solution is articaine. I prefer to use only 30 gauge. Okay, I will probably use 30 gauge 10 mm needle okay, a short one, or probably, or I will use 30 gauge, 25 mm. This is 1 inch needle. Okay, these are the two needles which I use. The needles which I use from Septodon, extremely sturdy, even if it is 30 gauge. Extremely good. I'm meaning I don't think anybody has ever experienced breakage with this needle. So there's no fear. There's no fear of any breakage or anything. So this is one of the tools one can use, and it has got it probably you can do aspiration with this, because the posterior part gets into the piston of the cartridge, okay, and we can probably pull it behind. Does it really happen? I don't know. It is questionable for me, but okay. So proven methods and ideas to help inferior alveolar nerve blocks. So what are the tricks which we can play and that can help us in making our inferior alveolar nerve block better? Okay. So use of buccal infiltration of articaine after inferior alveolar nerve block in mandibular force bullet increases success rate. Okay. And why does this happen? Because we know articaine has got affinity towards lipids. Okay, it penetrates through the bone easily, and the anesthesia significantly increases. The success rate of anesthesia increases to up to 88%, and that's a big number. That's a very big percentage. Okay, we giving lignocaine buccal shot, no help, but giving articaine buccal shot, the world differs, totally differs. Okay. So get into that habit of whenever you are working on lower 6, lower 7, it may not work that well because the bone anatomy starts changing over there. But lower 6, it works really, really well. Okay. Intraosseous anesthesia. If you can do it, if you can achieve it, if you have equipments to do it, the success rate is really, really high, and that is 90% plus. Okay. But what I prefer to use in my clinic is intraligamentary anesthesia and intrapulpal anesthesia. Intraligamentary anesthesia, again, I see the success rate close to 90%, and intrapulpal anesthesia is a pressure anesthesia which acts immediately. If given properly, it is instant, and it is one of the best anesthesia which we can use. So let's come to intrapulpal anesthesia first. Okay. So intrapulpal anesthesia with lignocaine or articaine, whichever you want to use. It is basically pressure anesthesia. Okay. So what does that mean? So this is a very old study. The study is done in 1975 or so, and which says that they injected saline, they injected distilled water, and they injected anesthetic solution into the pulp, and they found that it works the same. Okay. So it works basically because of pressure. So what exactly happens? Whenever we inject inside the pulp, the pulpal architecture collapses because of the pressure developed inside. The pulpal tissue is bounded by the dentin from all the sides. So when we inject inside the pulp, there is tremendous pressure created, and the whole pulpal architecture collapses. And that leads to anesthesia, not the anesthetic solution. However, I will still prefer to use anesthetic solution. Why? Because it has got that adrenaline, which is vasoconstrictor, and which will help me in reducing the bleeding happening from the canals, from the chamber. Okay, but it is not as easy as we say. Intrapulpal anesthesia is not that easy. It takes some expertise. It takes some time. So how do we do it? So whenever I have to inject, I will try and see to it that my opening is as small as possible. So I take just a small drop with a smallest possible round burr. Okay, I take a drop and I come out, and then I will bend my needle and I will enter inside. Okay, needle should be as thin, as small as possible. Even the hole should be, which has been done, should be as small as possible, so that we can create tremendous pressure inside. Okay, and then we inject. When we try to inject and nothing really enters, we create tremendous pressure but nothing really enters, that should be the sign where we should know that, okay, intrapulpal anesthesia acted really, really well. Now you will say, oh, but that injection is painful. Yes, I understand that injection is painful, but here we play a smart thing. We tell the patient, I never tell my patient, okay, that there will not be any pain. Whenever I'm working on tooth, which is vital, I will always tell my patient, okay, this is a hot tooth. And this is what happens. These kind of teeth do not get anesthetized easily. It takes time for them to get anesthetized. And initially, for the first couple of minutes, you may have some pain. So don't worry, I will take care of that. Okay, be with me as we try reaching close to the pulp, and as we are taking drop, that is the time patient has maximum pain. So take the needle, bend it, start developing a drop, enter inside, support at the angle where you bend the needle. To stabilize it, take other hand index finger and stabilize it, okay, and start injecting immediately, quickly, without wasting even a fraction of a second. Start injecting inside the pulp immediately. Patient gets pain, ask him, did you get pain? He'll say yes. Ask him again, do you really feel that you have got pain? Do you still get pain? He said no. Within fraction of a second, the pain is gone. He actually, this is how we mask the pain in his brain. He feels that he got pain. Yes, he got pain, but it disappears so fast that he feels, oh, he just felt it, but there was no pain. Okay, and we have eliminated the pain completely. So this is the trick which we master. When we master this trick in intrapulpal anesthesia, that even that pain which when we enter inside is not really felt by the patient. Okay, so interligamentary anesthesia. That is another favorite part of my anesthetic this thing, armamentarium. And I think, meaning, when we say we are dentists, we are painkillers, I really wonder, majority of us, why don't we have correct gadgets for it? Okay, most of us don't have anything to give interligamentary anesthesia in our clinic. The needle required is essentially ultra short 30 gauge needle. Okay, so 10 millimeter 30 gauge needle is the needle which we have to use essentially. If you think that you can use insulin syringe or something like that and give interligamentary anesthesia, it doesn't really work in most of the cases, because you need to create good amount of pressure, and which is difficult to make with this. So you require certain special gadgets. It's a one-time buy in life. It's a kind of a lifetime buy. Once you buy it, and it is forever. Nothing really happens to this kind of gadgets. Okay, so how much do you inject? Now, for example, if I use something like this, it's a clicker. I have to just press. Okay. Every time I click, it dispenses 0.06 ml of local anesthetic solution. So 0.06 ml meaning the cartridge is usually 1.8. So I will have to click this 30 times to empty the cartridge. 30 times. 0.06 multiplied by 30 is 1.8. Okay. So 30 times I will have to click. So that is such a small dose which has been injected. So what is the dose which is required for interligamentary anesthesia? We require 0.10 to 0.20 cc of anesthetic solution. So 0.10 to 0.20 cc meaning 2 or 3 clicks. That will make it 0.12 to 0.18. Okay. So if it is a bigger root like upper 1, 2, 3 or lower canine, I will probably require 3 clicks. A smaller root will lower anteriors will require 2 clicks. So many times lower anteriors, upper anteriors, I may just give interligamentary anesthesia. I may not give even the buccal infiltration or labial infiltration also. Sometimes for pulpal anesthesia, interligamentary anesthesia can be enough. Okay, we need to master it, and then it becomes really, really easy. So how do we do it? For molars, I need to inject on both roots separately. Where do I usually inject? I will prefer to inject on lingual side than the buccal side. Now you will ask me, why are you saying this? Why lingual side and why not buccal side? So here is the reason. When I'm injecting, when I'm giving normal block, and I'm using it as an adjunct to my normal block. Okay, when I give a normal block, when I enter from opposite side, inject and come out. I did not take the needle on the same side and come out. In spite of that, in 99% of the cases, lingual nerve still gets anesthetized. So lingual nerve anesthesia means my lingual mucosa is also anesthetized, and I am not going to give a buccal shot always, right? So when my lingual anesthesia is anesthetized, my lingual intraligamentary anesthesia will be painless, okay? Because even that entry point will be painless. So I will enter at the junction of mesio-lingual angle for the mesial root and disto-lingual angle for the distal root. This is the place I will enter inside as deep as possible and start injecting. Definite pressure and slow injection. Okay, so books say this is how we enter. Okay, but I usually do a small modification. and enter this way. So I leave some tissue and then enter. Why do I do this? Because so many times there's some food particle, especially the tooth, which is to be anesthetized. Patient has not been eating on that side, he has not been brushing properly, and there can be some calculus, there can be some food particles, there can be some what do you call plaque which can be there. And when I use the needle, and I may be pushing something like this into gingival sulcus, which I don't want to do that. Okay, I do not want to push something, because that can theoretically lead to some kind of inflammation in the periodontal area, okay, which I don't want. Okay, so I want to enter inside, but so I leave some tissue and I avoid this area and I enter through the clean gums inside, but not like this. I'm not going to inject to the papilla, I'm going to inject into the PDA, okay, and this is how we inject and we proceed. Okay, so the next tip which we can have is a slow inferior alveolar nerve block injection, more than 60 seconds, okay, results into higher success rate of pulpal anesthesia than a rapid injection of 15 seconds, okay. This also is less painful and works better. So what happens exactly? So we typically, when we want to give anesthesia, patient is already paranoid. Half of the patients don't want to go to dentist because they are scared of injections. And patient does not turn up, wants to come because there will be injection there and it will be painful. So when patient is sitting in the chair and we want to inject, he's either already under stress, he's closing his eyes, and we also are like, okay, let me give you anesthesia. Okay, let me make it as painless as possible. So we put local anesthetic gel or something like that. We have sprays also, and nowadays we are not preferring to use sprays because the sprays it creates aerosol. And in COVID times, we do not want sprays. We want a gel. We apply, we make that area numb, and then we enter inside. And we also want to finish that injection really, really fast. So we in 15-20 seconds we inject and we come out, and that makes it really, really painful. So what happens exactly? Imagine that there's something. So the tissues which were there inside, close to the ramus, okay, that area you're suddenly going to deposit around 1.82 cc of local anesthetic solution. So much of liquid we are suddenly going to deposit, and that is going to be sudden. There's going to be a blast over there. Okay, so tissues are literally going to tear apart. They're going to separate, and that's going to be a painful thing, right? That's going to be a definite pain. If somebody wants to give you something which is IV and which is going to be quick, that is going to be painful. Versus if it is given some injection which is given slow, naturally going to be less painful. Okay, so we should be going slow. We should be having some patience. So what do I do? So I have been, since last 3-4 years, I've been using local anesthesia boosting gun. And this is the gun which I use. There are different models available in the market, whichever you get. This is something which works well for me. Okay, and this is what I use. So this has got some speed settings, high, medium, low. In dentistry, what we need is high only. Okay, what is high? High is 1 ml per minute. And that's usually the speed for which is required in dentistry. And there is one on-off switch. That's it. Okay, it is very simple. There is practically no learning curve. What do? You take it and you just enter inside and you start injecting with it. Okay, you just press this switch, on-off switch. Okay, with your finger, you press it, it is on. You release it, release the finger, it is off. Okay, and then you start injecting inside. When you are injecting, the anesthetic solution deposited is extremely slow. So what are the advantages it gives me? Because there is slow anesthesia, because deposition is slow, dispersion of the solution is better, and pain is minimum, anesthesia acts faster. So many times I inject and I'm coming out, patient already has started feeling numbness on the lip. Okay, one. Second thing, the temperature plays extremely important role. So my room temperature should be, my AC is usually set at 25-26 degrees Celsius or 24 degrees Celsius. So my anesthetic solution also should be at the similar temperature. Now, if the temperature difference is more than 3 degrees, patient will perceive it as pain. So if I'm giving a quick anesthesia, that 25-26 degrees Celsius temperature solution is pushed to 37 degrees of body temperature. Okay, and that's a quick change of temperature. Patient perceives it as pain. Sudden deposition, temperature change. Whereas here the anesthesia which is given is 1 minute per ml. So if this is a cartridge of 1.8 ml, it takes me 104 seconds, like 1 minute and 40, so around 1 minute and 45 seconds of the time which is required to empty one full cartridge, which is pretty slow. But believe me, it is extremely painless. Patients just love this kind of injections. By the time you are giving injection and coming out, in fact, anesthetic solution required is also lesser. I may not require full. I may inject where I used to inject 2 cc. I may inject 1 or 1.5 cc, and that should be more than enough in majority of the cases. Okay, so I inject and I come out. So the anesthetic solution deposited is slow. So when the solution passes through metal cannula of the needle, it slowly picks up the body temperature, and that temperature difference is also much lesser. The pain of the anesthetic injection is much lesser. And third thing, it creates some vibrations, okay? And those vibrations actually dominate the pain sensation, and it is kind of fooling the brain because of the vibration, and especially this end somewhere touches the lip, okay? So patient feels some vibrations on the lip, on the cheek, other part of the mouth, and because of which patient does not really come to know the pain. Okay, so that is a big advantage which you have with this, especially in upper infiltration. Patient in fact tells you that, oh doctor, you injected, I did not even come to know. Okay, it can be that painless. So this is a stand for it, which can also be used for as a charging station. Once you charge it, you can usually use it for around 100 injections. So one charge usually will last you for maybe a month or 2 months. That's pretty long. It takes only 2 hours to charge. Okay, I use it for my inferior alveolar blocks also. I have no issues in giving blocks in inferior alveolar blocks, and for that also I use RTK, if you have noticed. Okay. Now probably the most important tip which I'm going to give in today's lecture, and that is role of OPG in mandibular anesthesia. You will say, what is that? Why? What is the role of OPG in mandibular anesthesia? So here we go. Okay, so if you see this case, see the OPG. Now don't ask me which tooth is for root canal over here. I'm not showing you these OPGs for that, but I'm going to show you something important. Where do we inject when we give mandibular anesthesia? We inject on the ramus. And where do we inject on the ramus? We inject close to mandibular foramen. And where is the mandibular foramen? Where do we exactly inject? We say we put our thumb in anterior fossa and imagine a line bisecting the nail 1 centimeter ahead of that. This is the place where I'm supposed to inject. Isn't that right? That is what theory says. But in practical, no. We do not always have mandibular foramen over there. So if I'm going to inject somewhere over here, is it going to work? No. This is my mandibular foramen, and this is where the nerve enters inside. So I am ideally supposed to inject around 1 centimeter above that. So if I have to show you over here, so this is the mandible I have. I hope you can see properly. And this is the mandibular foramen. Okay, and I'm ideally supposed to, and here the nerve is going to enter inside. So I'm ideally supposed to be depositing solution somewhere over here. Isn't it right? So this is where I'm ideally supposed to be depositing a solution. So this is going to be ideally somewhere here. Now look at this. This is the fossa. This is where I'm going to deposit solution. Am I really going to go deep so much? No. Same over here. This is the fossa. Somewhere here I'm going to deposit. Okay. So if I divide my mandibular in 2 vertical arcs and 2 horizontal arcs, even in the same picture, if you see, these openings are at different places. This is in this is in this area. They both are not in same place. Okay. This is below the occlusal surface, and this is above the occlusal surface. Okay, and this is way far behind. I'm supposed to inject somewhere over here. If I'm going to inject over here, patient is not going to get anesthetized, or he's not going to get anesthetized well. Then I will inject him again, and I'll keep asking, are you feeling numb? Are you getting the numbness on the lip? He may feel numbness on the lip, but his tooth is still not numb. So I inject couple of times more. Okay, so I deposit so much of solution over here that some of the solution actually percolates over there and somehow makes the nerve numb. Okay, show you another picture. See this. In this picture, same patient, 2 different sides. And if you see, this is the plane of the lower teeth. And if I follow plane of lower teeth, this is the mandibular foramen opening over here. So I'm supposed to inject above this plane. Okay, whereas on the opposite side, this is the plane of occlusal plane of lower teeth. Okay, that is my anatomical landmark which I see from the mouth, and this is where I'm supposed to inject. But is it going to work? No, it is not going to work this way, because this is ideally I require injection below this occlusal plane. So I always say, whenever possible, take OPG of the patient. Whenever, meaning I'm not asking you to take OPG for anesthesia, but when you have it, you can use it. And if this patient, suppose if I have done root canal for this tooth, suppose, okay, this tooth does not require root canal, and if this patient comes for root canal for the premolar after 5 years, these anatomical landmarks are not going to change. I can always use the same old OPG as a reference. Okay, so for me, every X-ray is stored in my system, and it is a digital record on cloud, so I can refer to any damn X-ray which has been taken for my patient in last 12 years. Okay, so I can go back to any old OPG which is 5-year, 10-year old, and I can still see I do not require for this tooth. I require now if I have to do root canal of this tooth after 10 years, I don't require OPG. I can refer to the old OPG, and I know, okay, I'm supposed to change my direction and I'm supposed to go below the occlusal plane. Okay, and it is a common thing. So this is a rule in my clinic. Either me or my associates always will first look at the OPG on computer screen and decide where we are going to inject. Are we going to go a little deeper? Are we going to go much above the occlusal plane? Are we going to go below the occlusal plane or something like that? If you see over here, see this so much in posterior. This is the mandibular foramen, and this is where I'm supposed to inject. Again, here, this is below the occlusal surface of lower teeth, because this is where the mandibular foramen is. Okay, so this is the place where I'm going to inject. Another case, similar. Again, on both sides, it is different. Here, it is way above, just below the base of the condyle. This is where I'm supposed to inject in this case, because mandibular foramen is here. Okay, where it is below the occlusal surface of lower teeth on this side. Okay, so here we come to the case which I showed you at the beginning of the lecture. This patient came, the Indian NRI, Parsi guy who was traveling to Australia next day morning, and he came, and my associate injected him and it did not work. I injected him, it did not work, and then I was like, it is 9:30 in the night, what do I do now? And then we decided to then I suddenly remembered, oh, he has been coming to me since long. Let me check if we have his old OPG. I found his OPG, which was taken in 2015. Okay, I found this OPG and I saw this. And here, this is what I realized. I was depositing my solution somewhere over here. But in his case, if you divide his mandible, his rhombus into two parts, it is way much in posterior half. If you see, it is so close to the posterior border cortical plate of the mandible. So, and 1 centimeter above that is somewhere I'm supposed to deposit over here. So if I continuously was depositing solution here, where I was supposed to deposit here, what I did was I injected him again. I went deeper, okay, slightly above the occlusal surface of lower teeth, and I went deeper and I injected him. And within 10 or 15 minutes, he had profound anesthesia. We could do his root canal in single sitting very easily. Okay, why do I prefer cartridges over syringes? Well, world over, most of the countries don't use syringes, or most of the countries don't use vials. It is something which we use it in India, and with COVID times, so anyways, we should not be using them. Okay, so typically there is a needle which has been put inside, and it is never removed unless the bottle gets over. The remaining portion of the bottle is filled with air. This continuously keeps oxidizing the solution. Okay, so this was a study which was done in 2017, and typically the study was done in India, and which says the concentration, the needle which is pricked for longer duration inside will change the pH, the concentration of the vasoconstrictor, and it will deteriorate the properties of the local anesthetic solution. Do we really want something like this? There is passage of air, continuous passage of air in and out. Okay, there is air over here, there is oxidation happening. Do we really want to use something like this which doesn't have full potency? Why should I have, and probably this can easily get infected. Okay, this solution may be an infected solution. Do we really want to do that? No. If we use cartridges doesn't even have an air bubble. We do not really worry about all these things. If you use good company cartridges, like say, for example, Septodont, they are ethyl paraben, methyl paraben free. Girls, you use your makeup things, and it is paraben free. That is what they write. We know that methyl paraben can lead to severe allergic reactions. So usually, if you see, the true allergy to anesthetic solution is usually, in majority of the cases, is basically because of parabens. And if the parabens are eliminated in cartridges, we will not really have reaction. It becomes extremely rare to have any reactions. Okay, and why do they add ethyl methyl paraben? Because they want to avoid growth of bacteria and fungi. That will happen in this kind of scenario. It is not going to happen in cartridges. That's why definitely cartridges are preferred. Now, very important thing, alternative to local anesthetic solutions. You all write painkillers, right? So patient has pain. What do you prefer to write? Some of you prefer to give diclofenac. Some of you prefer to give ibuprofen. Some of you prefer to give combination of diclofenac, paracetamol, ibuprofen, paracetamol. Some of you will write only paracetamol. Some of you will prefer, like we have been writing ketorolac quite commonly during these COVID days when we were not opening our clinics because patient had immense pain. Okay, so we have our preferred molecules. Some of us write aceclofenac, paracetamol. So we all have our preferred molecules. But do we write the same molecule throughout our life? No, we change. Sometimes we write ibu para combination, but it does not work. So I will probably write ketorolac to this patient or piroxicam to this patient. So we keep changing our painkillers. Okay, talk to any general anesthetist. Ask him if he's going to do a heart surgery. Will he use only one type of molecule for all 100% patients in the same concentration for that particular type of heart surgery? No. He will always change the solution, the molecules as per that case, right? So if that is the case, why do we use only lignocaine? Sometimes it does not work well. Okay, so we should know some of the options. So one of the options that we can have in our clinic is bupivacaine. Okay, remember, we know bupivacaine as long-acting anesthesia. The Sensorcaine is a brand name. Onset is typical 2 to 7 minutes, which is a typical onset, but duration of action can be 2 to 9 hours, or sometimes I've seen it remains effective for 12 hours. So it is like 10 o'clock in the night. If I inject you now, it probably will anesthesia will wear off at 8 o'clock or 10 o'clock in the morning tomorrow. Okay, so take precautions, especially if you are using it in children. It is known to be cardiotoxic. So if your patient has cardiac complications, you probably can avoid using this solution. You can combine, you can take say 1 cc of lignocaine and you can take 1 cc of bupivacaine and combine them together and inject. It works better. Effect is synergistic. But my preference in my clinic is not lignocaine, not bupivacaine. For me, all my 100% cases, of course I have bupivacaine in my clinic, but all my 99.99% cases are with articaine. Okay, so articaine is a dental amide type local anesthetic solution, because of which, and it has got thiopine ring, because of which it is thiophenic, that will convey lipid solubility, and that makes it more effective. Okay, so when we use articaine and when we compare it with lignocaine, articaine, the onset of action is faster, so it saves me time in the clinic. The duration of action is longer, the success rate is higher, the potency is 1.5 times more. Okay, and systemic intoxication is lesser. It's a very safe drug. Okay, you can use it for all the cases. The brand name is Septanest, and articaine used to be expensive in India than lignocaine. I just had a word with Septodont team in India, and they just told me that they want to popularize articaine in India. If you go to Europe, the majority of dentists use articaine. Okay, if you go to US, or almost 50% or more of dentists use articaine. World is changing to articaine. Okay, to make it more popular in India, Septodont has reduced their prices of articaine, and the price of articaine is lesser than lignocaine at this stage. Okay, so I'm really happy that they have made it the price. They've reduced the price, which is lesser than lignocaine. That will definitely encourage a lot of dentists to use Artican. Try it in your clinic, and probably once you start using Artican, you will get hooked. You will not want to go back to lignocaine. I will do anything to reduce the pain of the injection, to reduce have that painful in thing, and I want to have more potent anesthesia so that my patient experiences painless treatments. Okay. Now in Artican, there is one more thing. The pH of Artican is very similar to our body pH, whereas the lignocaine pH is slightly acidic. Okay, slightly acidic. So that's why lignocaine gives that initial stinging pain because of the acidic pH, which is not there with Artican. That also makes it less painful. Okay, so what do I use in my clinic? I use this sunshine gun, wet Artican. That is what I prefer to use in my clinic. I essentially use 30 gauge needle and 1 inch needle, and this 1 inch needle I can use it for everything. I can use it as for the block. I can use it for infiltration. I can use it for intraligamentary anesthesia. I can use it for pulpal anesthesia. All anesthesia I can do with this, with my Artican. Okay, so friends, take home points for our lecture. Slow anesthesia. Okay, slow anesthesia. You will say, okay, I will try start giving slow anesthesia from tomorrow. Okay, you said 1 minute per ml. I will take 2 minutes to finish the anesthesia. Well, try it, but it is very difficult, and you really require patience. It's not that easy to give anesthesia that slowly. Okay, you require a lot of patience, and sometimes you just inject. It pushes a little bit of solution, and then you look at the watch, and then you see, okay, 1 minute is over, and more than half of my solution is gone. So I should start giving slow anesthesia now. It doesn't work that way. That's why these special guns, where the anesthetic solution is deposited at a continuous low speed. Okay, thinner the gauge of the needle, lesser is going to be the pain. I see a lot of dentists using 24, 25 gauge needles. Why? It's just a small cost. Maybe 10, 15 rupees is something. When you start we shift to the cartridges, the needle, the cartridge, and everything. The cost of your anesthesia will use by say 15 rupees extra. Charge extra 15 rupees anywhere in your consultation, in your whatever treatment option. 15, 20 rupees extra if you charge, and you're not ever really going to increase your charges. You will increase that by 50 or 100 rupees anyways. Okay, and you will be able to use best of the things in your practice. Give time for pulpal anesthesia. It takes time. Don't be in hurry. If you're in hurry, it is not really going to work well. Okay, especially with mandibular teeth, especially with mandibular molars, you have to give some time. Prefer using Artican. Your anesthesia potency will be much higher. The duration will be more. Give a buccal shot in case of mandibular molars, especially first molars. Okay, and your pain will be taken care really well. As studies say, 88%. For me, almost 90 to 100% of the cases, there will not be anything. Look at OPG. Please start looking at OPG from tomorrow onwards, and then decide your angulation. Are you supposed to go deep? Are you supposed to go towards on the upwards? Are you supposed to go below the occlusal plane of lower teeth? Change the direction and work. And believe me, by the time you are coming out, patient will say, "Oh, I'm already getting numbness in my lip." Okay, and that is the experience you will start getting. This one single tip will make a great difference. You don't have to be in that dilemma where you keep asking the patient, "Are you feeling numbness? Is it getting numb? Aapko heavy lag raha hai kya?" You do not have to really ask the patient that way. Learn intraligamentary and intrapulpal anesthesia. This is really, really important. We have to know 2-3 techniques, right? As dentists, we must know. It's just we can give block and we can give infiltration is enough. No, we need to learn intrapulpal and intraligamentary anesthesia also. Okay, with which I end my session. Anand, Abhishek, you guys are there? Hello? Okay, so I'm in live comments and a lot of questions. Lot of questions. Where am I? So here we take some questions. So, hi Anand.
Hi,
Have
sir.
you?
Hi.
Hi. So do you have some questions? Have you seen some questions which are not repeat or something? I will take
We are
them.
shortlisted some questions, sir.
Okay.
2
Okay.
minutes.
So much, sir, for the wonderful presentation. There
Pardon
are
me.
plenty of questions,
Okay.
and we are
I hope you
practicing
have time.
dentistry, and anesthesia is the most ignored part. And
Yes.
it is not possible to practice dentistry, not even for a single day, without having adequate knowledge about anesthesia.
Hmm. Correct.
Can I take some questions, Abhishek?
Yes,
Yes.
yes, please.
Yeah. So, sir, there is a question from Dr. Rashmi Verma. She is
Hmm.
asking if Articaine is safe in children.
Yes, Artican is safe in children. Artican
So it can be
is
used.
definitely safe in children. In fact, I will prefer to use Artican over, if at all, if I have to change. Lignocaine works, frankly, Lignocaine works well in children because the bone density is lesser, bone is thinner. Okay. In fact,
Yeah.
if you, I really do not do children dentistry, but they say you sometimes even don't require lingual anesthesia, even for extraction. Buccal shot is enough, right? In children, right? So it works well. Artican, I think we rarely will require in children, but it is safe. We don't really have to worry about that.
There was this
Yes.
one doubt. Many people have been asking, can you repeat or redescribe the mylohyoid nerve anesthesia technique that you were talking about?
Okay. Okay. So, okay, I'll show you with the mandible. Okay. So we have this mandible in our hand, and uh, if you see, this is the place where my inferior alveolar nerve enters. Okay. I'm finding it a little difficult because this is a what do you call mirror image, so it's a
Mirror
little
image.
difficult for me to imagine. Okay, but I will look at the tooth, this thing and see. So this is the place where my mandibular nerve comes, and it gives two branches. It gives one branch. One branch is myloid nerve, okay, which branches before the inferior alveolar nerve enters inside, okay, mandibular foramen. Okay, so around 1.5 or 1.8 centimeter before it branches out. So there will be a branch which will be going from here. Okay, now this is ideally a nerve, which is a motor nerve, which is supposed to be innervating a muscle. Correct? That is myloid muscle. And what is myloid muscle? This is the muscle which forms the floor of the mouth. Correct? Okay, and which is essentially the this is our mandible. Okay, and there is floor of mouth, and this muscle forms the floor of the mouth. Okay, so this is essentially on the lingual side of the mandible. So nerve is also on the lingual side of the mandible. So I will prefer to inject. Now I have to simply imagine if this is the molar. Okay, this is the place where I am going to have my apices. Okay, and this is the place where myloid nerve passes. So this is the place where I will be. So around this is going to be around 1.5 centimeter. If from the cervical level of the tooth, this is the place where I will be injecting. Okay, on the lingual side. This is my buccal side, and I will be injecting on the lingual side. Okay, I'll give you a simple example. Sometimes even extractions are painful. Try and give this anesthesia, and you will find that extraction becomes easy. If oral surgeons typically will agree with me with this, that whenever you are doing impaction, sometimes impactions are extremely painful, especially when you are splitting the tooth. While splitting the tooth, you are going through the pulp. The tooth is gone numb. Guttering is not painful, but splitting the tooth is painful because your pulp has not gone numb. Okay, this is a typical example. Your pulp is, but once you go through the pulp, once you cut the pulp, once that is done, that splitting is done, then the pain disappears. Okay, so that's why there also I will say, even for the oral surgeons, take a dip into that tooth, take the way we take a drop, the drop into the pulpal chamber, inject into, give a pulpal anesthesia, and then you continue with splitting. Your disimpactions will be painless. I do my disimpactions in my clinic on my own. So this is how you do it, and they really become painless.
Okay.
Sir,
Yeah.
I had one doubt for this. So
Yeah.
when we are giving this anesthesia, should we
Hmm.
see ballooning of the tissue, or we are supposed to see blanching of the tissue? Will the
Uh,
solution cause ballooning or blanching?
yes. Yes. So I will prefer to see a blanching. Ballooning is going to be, although the studies say there's a couple of studies which say there's hardly any difference in final anesthesia, but I will prefer to deposit my solution as close as possible to the bone, ideally between the bone and the periosteum. That is the place ideally I should be. I don't know whether I will be achieving that or no, but closer deposition to the bone, faster it is going to reach to the root apex.
Thanks a lot, sir.
So
Vishal sir was asking, do you think we need to give palatal anesthesia when we are placing rubber dam, especially when we intend to maybe, trim the interdental papilla or something like that?
that is the time we essentially should be giving. Yes. So, but from endodontic point of view, a lot of people feel that, oh no, I should be giving him for endodontic treatment also. But I personally feel, why do you really require to give for endodontic treatment? I will be where if I'm going to place my rubber dam clamps, which are going to injure palatal mucosa, then I require it. Otherwise, I don't, and which we normally don't intend to. I don't want to do any injury to the palatal mucosa, so I don't need to. But when it comes to restorative dentistry, we need to play with gingiva a lot, okay? And there where, yes, I will require. Probably I can give pulpal papilla into gingival this thing, sulcus only. I can give interligamentary, or I can give a full-fledged palatal anesthesia. In that case, yes.
A question from Manan Vyas. Does sunshine gun has an aspiration option so that at
Is
least
a
not
question which I always wait. And well, this gun does not have aspiration, okay? But there is another model of this gun which has facility to aspirate. Now, typically, most of us who use cartridge anesthesia cannot aspirate. They do not anyways aspirate. There is no facility of aspiration in most of 99% of the cases. Okay, so world over, most of the dentists are not aspirating. Now, this is the one which I'm showing you over here, has a facility to aspirate. I'll just try to pull this away and see. Okay, so it has got a tip which pierces inside the rubber of this, and then, but again, whenever you try to aspirate in a cartridge, what happens when I aspirate inside a cartridge? When I'm aspirating over here, I'm going to pull the air inside, okay? And this air bubble will never release, because the difference between a needle syringe and a cartridge is different. In a needle syringe, the needle is on the top of the stub which we have on the syringe, okay? But here the needle is going inside the cartridge. So removing that bubble is difficult. So there can be a fear of air emphysema. So those who are using cartridges usually don't prefer to aspirate. Now you will say, oh, if you don't aspirate and you are going to give block, what if you enter in a blood vessel? Okay. So tell me, friends, what happens if I enter inside the blood vessel? Sometimes it happens in spite of aspiration, sometimes we enter. What happens? Okay. Here the anesthesia is extremely slow. Okay, it takes 1 minute for me to inject 1 cc. So if I'm injecting in 10-15 seconds, patient, if at all, if I'm in blood vessel, patient will feel it leads to slight amount of tachycardia, nothing more than that. Okay, so we come to know this. Please don't worry. There are no accidents which are going to happen in your clinic. Okay, it is lignocaine which is entering into bloodstream. So there will be some amount of tachycardia which patient experience, but that amount is going to be much lesser because in 15 seconds you have just deposited 0.25 cc, and by then you know about it. Okay, and you can always change the direction, which you immediately learn in say a couple of cases. So in last 3-4 years, I'm not aspirated in any of the case.
Wow. Sir, could you just show us the machine? Could you just give us a small demonstration or something? You have it right now?
Yeah, I have it because I'm in my clinic. So I have it. Just give me a second.
It would clear a lot of doubts. Yeah.
Okay.
By the time sir joined us back,
do
give us your suggestions and opinions. How can we improve for the further sessions?
How can we?
He was asking for feedback.
Okay. I didn't hear what you said.
Sir, please continue. Abhishek.
Okay, so I just put a
Sir,
needle.
please continue.
Yeah. Okay. And this is the gun which I have. Okay. This is on-off switch. Okay. Here you see a light. That means it is working. When this light goes red, that means your battery is getting over. Okay. So this is, and when the and you can see. Okay, I have already finished my coffee, so I can put some drops in this, and you can see the drops coming out. Okay, so it takes around 104 seconds for me to empty one cartridge. I have set the speed at high over here. Okay, usually in dentistry you require high. They use it in dermat also for some of the reasons where some of the anesthesia they will use it at medium or low. For palatal anesthesia, if at all, you can use it at medium, but usually high is more than enough for all of us. So this is an on-off switch. So when I'm going to work in patient's mouth, I can hold it like this. If it is going to be upper, I can hold it like this, and I can simply enter and inject. It's pretty simple. There's practically no learning curve.
Thank you. Thank you so much, sir, for the
OPG distortion.
OPG distortion, yes, it is a possibility. I hope the OPG center which you are working with gives you good OPG. Or it can be simple that patient's jaw is not symmetrical. Okay, sometimes the angulation which we have is different. Okay, so there can be distortion. Okay, that's always a possibility. But still, it does give me, okay, this is the place where mandibular foramen is. Now, typically we feel, okay, this is the ramus, this is the place I should be getting it. Go to your clinic tomorrow and see put 10 OPGs in front of you and see. You will find that sometimes it is here, sometimes it is below the occlusal surface of lower teeth, sometimes it is closer to the posterior border or anterior border or somewhere in between. Okay, so this keeps changing. If I have OPG and if I see this and injected, believe me, it's just 1 or 2 minutes and patients start telling you, okay, I'm already getting numbness. Okay, and this kind of guns where it is anyways takes you 1.5 to 2 minutes to inject and you're out, by then patient always starts feeling numbness.
I think we are done with today's question.
Anand,
do you have any question? Anand, do you have any question?
I have lost internet. I can't see anything. I had one question for sir.
Okay.
Sir, ligament anesthesia. I have still not understood how
you're talking about it since long. Intraligamentary anesthesia, what can I do? I can probably take a model. Just give me a second.
Yes, please, sir.
Abhishek, I'm not able to see any of the questions, so if you can, please.
Okay, so
yes,
I showed some slide. I showed some pictures, and in which I showed it actually. So whenever I want to give intraligamentary anesthesia, okay, so what is the place that I should be choosing? Just remove the, just bend the needle. Okay, I will always prefer to use a smaller needle, maximum 1 inch, not more than this. Okay, and when I'm injecting, oh, this is total mirror image. Let me just look at my model and work. Okay, so I will always prefer a line angle. Okay, so if I'm working in a molar, if it is a mandibular molar, now this is actually a maxillary molar, mandibular, there are no mandibular molars, this is actually an implant model. Okay, so if I'm working in say mandibular molar, I will prefer to inject on the lingual side. And if I'm working in maxillary molar, I will prefer to inject on buccal side. Why buccal side? Because when I'm working on buccal side, it is definitely going to be, when I'm working on buccal side, it will be, I have already given a buccal anesthesia, right? So because of which that is going to be painless. And we don't prefer to give palatal anesthesia in upper, okay? And in mandibular teeth, lingual nerve anyways get anesthetized. So injecting on the lingual side is easy, okay? Now I will enter inside, I'm showing it on buccal side to make it easy. I will go from the papilla side, but I will not go to the gingival sulcus. I will not prefer to go through it. I will prefer to go 1 or 2 millimeters away from it and then enter inside, because I do not want to push any plaque or
Interdental papilla.
or plaque or calculus or some food particles inside. Otherwise, that can lead to inflammation sometimes. Okay. Now, essential thing which we have to remember in whenever you give intraligamentary anesthesia, tooth slightly pops out of the socket. Okay, because you are depositing something in into the PDL space, and of course there is going to be a minor injury to PDL because of this. So the tooth, there will be some inflammation and tooth pops out of the socket. Okay, and this is very minor. Okay, but that is of a great importance for me. Where there what changes in this? I should not forget to do occlusal reduction. If I don't do this, this tooth is going to be tender. Okay, it takes around 24 hours for this to settle down back, but till then the tooth can be tender. If I do occlusal reduction, I will not have any problems. Okay.
Okay, sir. Abhishek.
Yes, yes. Question from Ajmal Najib. Buffering of LA, sir. He's asked 2-3 times. Buffering of. Can you please?
Buffering of LA has been there, and they say that you can buffer it. You can use alkaline solution like NaOH or something like this. But I don't know. Meaning, I feel ki why do you? Because it is acidic and it can give you pain, so you buffer and you make it a bit on alkaline side and then use it. Instead, I will prefer to use articaine. And buffering, I have seen people, I've seen some of the videos on YouTube. How do we buffer the solution? They take the solution out, then they mix it and they put it back. I don't want to contaminate my solution. I do not, how do I guarantee that there is no contamination? So I will not prefer to do that buffering in my clinic and then inject. Although it works well, pain is lesser, anesthesia is better, I probably will shift to articaine in that case.
2 quick questions, sir. In which cases you give only intrapulpal anesthesia without any block? Or another question, can you give intraligamentary and intrapulpal anesthesia without inferior alveolar block?
So Anand and me knows Dr. Sunil Goel. He's been our teacher, and we have an endodontist in Mumbai, and everybody knows him, of course. Dr. Sunil Goel almost always exclusively uses intraligamentary anesthesia for all his endodontic needs. Okay, in 90% of the cases where he gives anesthesia is only intraligamentary. So there are people in the world who have mastered intraligamentary anesthesia so well that for endo they use only intraligamentary. Okay, now if I have a case of anterior tooth trauma where I can see that the say angular angular fracture is there and pulpal exposure is there, I can directly inject inside the pulp. Intrapulpal anesthesia is more than enough for me, right? As long as I can produce pressure, okay, which is going to destroy the pulp. If I could produce pressure, I can use intrapulpal anesthesia in almost all the cases.
So I have 2 more questions for you.
Okay.
There was a question from Dr. Parag Sakpal. He was asking, after we have done the cleaning and shaping, sometimes in the next appointment, especially in the apical region, the patient experiences a lot of pain.
Yes.
I have personally also experienced this quite
right.
a few times. And no matter what we do, it just doesn't go.
Yes.
So what can we do for that?
Okay. So first thing first, why does this happen? Okay. So in fact, so many people, so many dentists say and they question, oh, it's good that I did not do single setting RCT because probably there was some pulp issue left and that is giving me pain. Okay. See, try to imagine there is a tooth, there are some nerve bundles traveling in the bone. There are some blood vessels which are traveling in the bones, and some of them have given branches inside that tooth. Okay, and those branches which have entered inside the tooth create a pulp tissue inside. So when we do pulpectomy in first appointment, we may have done a perfect job. We may have done everything. When we have done pulpectomy in first appointment, ideally, if it is a vital tooth, I will prefer to do single setting. In today's date, anyways, we prefer to do single setting with the COVID. Okay, we want to reduce the number of appointments for the patient and for our safety, both. So we prefer to do single setting. But when patient comes in the clinic, and if I, for some reason, if I cannot do single setting, I've done pulpectomy. What happens is body actually tries to repair. It feels, oh, it has lost an organ. So body tries to repair. So the main blood vessel which was traveling will give some capillaries inside. It cannot replace the whole pulp tissue, but there will be new capillaries which will be forming inside. There will be new nerve ending which will be entering inside, and they may enter only for 1 or 2 millimeters. Okay, and because they are fresh, new, there is inflammation in that area, because of which it is extremely painful. Okay, so we try to push the file. So my working length in previous appointment was 20, and here I reach to 18, 18.5, and patient jumps in pain, right? And I feel, why should patient have pain? So this is the reason why patient has pain. So what do I do to avoid this issue now? Okay, fill the canal with something, which will not let this growth happen. And the ideal material for this is calcium hydroxide. Even if you can make a thin slurry, meaning you don't have to put a paste. You just, when you put calcium hydroxide slurry, you mix it with saline, you mix it with water, and then you kind of flush. Okay, of course it is antibacterial, but I'm not using it for that because it is highly alkaline. The environment for the new tissue to grow over there is just not ideal, and it will stay over there. And when patient comes next time, he will not have any pain. So in this presence of this, there will not be any tissue growth happening, or it will probably physically blocking that area, and we will not have. So even if the tooth is vital, you can use calcium hydroxide and avoid this kind of pain in next sitting.
Great.
Okay.
Abhishek, I have one more question. Abhishek?
Yep. Go ahead.
Yeah.
Anand.
Yeah.
Yes.
Yeah. So people were asking, okay, articaine is fine, but some people are still using lignocaine in the vials. So what is your opinion about plain anesthesia without adrenaline? Do you suggest using it in hypertensive patients or such patients, or is anesthesia with adrenaline fine?
Yeah. So, okay, now this is a controversial topic, but I will give my opinion over here. Okay, and this is what I have been following, and this is like I spoke to some of the cardiologists, cardiac surgeons, or anesthetists, and most of them have this opinion. What you are using, the adrenaline which you are using is a very less percent. Okay, so we are using 1:100,000, that is 1 lakh, or 1:150,000. Okay, that is a dilution, and that is very, very diluted. Okay, we do get some lignocaine solutions in the market in vial, which has 1:50,000 also. Okay. So higher the concentration, it is going to give me better vasoconstrictor effect, and the effect of anesthesia is going to last longer. You just try using plain lignocaine; it just doesn't work well. Okay, it's poor. Anesthetic action is lesser. Anesthesia does not last longer. It's like half an hour, 45 minutes, and you need to inject that patient once again. Okay. Now the patient is going through pain. Patient is going through agony. His treatment is painful. He produces more adrenaline in his body than what we are going to inject. Okay. So if at all, if somebody wants, but if somebody is really worried about adrenaline, he can use something at 1:1 lakh or 1:150,000. But you use adrenaline at a lesser concentration. It is safe. That is what all the cardiologists or anesthetists say. At that concentration, it is definitely safe. Anyways, what we inject is 2 cc or 3 cc, not more than that in most of the cases. Okay, or you can use half of plain lignocaine and half of with the adrenaline with vasoconstrictor. You can mix both of them together, and then you can use together. It will serve the purpose. If you're using, say, 1:50,000, that is what you have in your clinic, you can dilute it by using both 50-50%. That will take it to 1:1 lakh. Right?
Sounds good.
Okay.
Thanks a lot, sir.
Thank you. Can I make a small announcement over here?
Yes, sir, please.
Okay.
Please.
So if you follow me on Facebook, we have I've just been appointed as external professor and a course director in University Jaume 1, and we are now a team of 10 dentists, and we have come together, and there are people who are best in their field, and we have come up with a nice diploma course, and I appeal you over here, join us for this kind of sessions. Like if I say that anesthesia and endodontics is my forte, they are my team members, and their forte is, some of them have retreatment is their forte. So we have team members who's like really good at microsurgery. Somebody is really good at rubber dam. Somebody is really good at MTA. Okay, so we have our team members, and all of us are going to divide our subject topics, and we are going to give you best of all in this course. I welcome you to join this course. Thank you so much. Thank you, Anand. Thank you, Abhishek. I really adore you guys. The kind of hard work which you are putting, absolute selfless work which you have been putting since last 3 months, and I think it's not only dentists from India, but dentists world over are just going gaga for you. They really adore you, and hats off to your commitment. Seriously. Thank you.
Thank you so much, sir, for your appreciation. Coming from you means a lot to us, and we will continue to work like this in future as well. Thank you so much for your wishes
Thank
and
you.
a wonderful session.
Abhishek, if you remember, we met exactly 1 year ago. In last June,
Yes.
I was there in
1 year ago. Yes.
Amritsar to Jammu. I was
Yes.
skipping. I was traveling, and Abhishek called me, and
Yes,
I said, "Sir, आप breakfast आप मेरे साथ लेने वाले हैं." We went to this place, and lovely place next to the riverside restaurant, and had breakfast over there.
Yeah.
And if you remember that time, I asked you, Abhishek, you have such a nice platform, World Dental Association. You can do a lot of things, and I'm so happy to see that you are doing so many things. Of course, Anand to mera buddy hai Mumbai mein, so and he's been a very instrumental in this again. You are really doing fabulous job. That's really great. Thank you.
Thanks a lot.
Thanks a lot.
Thanks a lot, sir. It was
Thank
a
you,
very,
Viva.
very nice
Thank you.
session. I'm sure.
Thank you.
Yes, I'm sure a lot of
Thank
doubts
you.
have been cleared, sir. Bye, sir.
All right.
I guess Abhishek has a few
you.
appointments, few announcements to make.
Yes. Please do that. Questionnaire, we will be posting it tomorrow morning. Those questions which have not been answered, they may be answered tomorrow or later on. We will request sir to do that. And any queries and any suggestions, please mail us, message us. We will be more than happy to answer it. Thank you once again.
Thanks a lot. Thanks a
Okay,
lot,
bye-bye,
everyone.
Anand. Good
Bye-bye.
night.
Good night. Bye. Good night, Abhishek.
Bye-bye.